Now, we're going to return to AI. Well, this morning we heard about the massive opportunities that Gen AI is creating this afternoon. We will look at one industry where AI is making an especially remarkable impact. Don't forget to submit your questions for our speakers using the Forum app. From diagnostics to delivery, AI is reshaping the healthcare industry. So let's welcome back to the stage Marissa King, the Alice Y. Hung President's Distinguished Professor. She'll be joined by Dr. Chris Fang, Chief Commercial Officer at Hippocratic AI. Dr. Sunita Mishra, a highly accomplished physician executive and the former Chief Medical Officer of Amazon Health Services, and Donna Situ, the Senior Vice President of Sales and Life Sciences and the General Manager for pre-IPO companies Komodo Health and Clarify Health. Welcome.
It is fantastic to have the opportunity to think about AI in healthcare after such a vibrant day of discussion about thinking about AI in general. AI is now touching almost every space within healthcare, from drug development to the bedside at this point. But what makes healthcare particularly interesting as a case is it's in many ways an extreme case of one of the fundamental challenges that we have to consider as AI infiltrates society. Healthcare has always had to balance a focus on health, so being technically excellent, but also care. Thinking about how to combine technical excellence with compassion and empathy. And so we're going to explore these questions of how do you balance technical expertise with compassion and empathy as we implement AI throughout the panel. The other reason that healthcare is an extreme case is while the opportunities in this space are immense, the consequences are also really life and death. So I'm thrilled to have such an excellent group of panelists today with me to think about how can we harness these opportunities while ensuring safe, efficacious, and cheaper care for patients. So please join me in welcoming the panel. So I briefly alluded to the many opportunities for AI in healthcare right now, and you all sit in very different positions with respect to thinking about the intersection of business, AI, and healthcare. So I'd love to get us kicked off by asking you first where you think the greatest opportunities are at the moment. Chris, you want to get us started?
Sure, thank you. First, thank you for the introduction. I think the single biggest opportunity in use of AI in the healthcare delivery is agentic AI. For the first time in history, we actually have abundance in healthcare delivery. For most of us, our entire career, in fact, entire history of delivery medicine, we have been taught about rationing. The whole idea of stratification, risk stratification, because the fact that we don't have enough resource. For the first time, we actually have abundance that the only limitation is actually the number of GPU you have. So because of that, we're going to have ability to decrease burden for clinicians, improve health outcomes, and lastly, fundamentally decrease cost. And that is tremendous opportunity. In fact, I believe we're only just in the very beginning of our ability to do that. And that's what really makes me excited about being in this space.
I'll go next.
Sure.
I would agree with you, Chris. I think that the opportunity to improve health outcomes is finally here. It's a super exciting time to be in medicine because we finally have these tools that will allow us to give our clinicians the ability to, I like to say, make our doctors smarter. Right now, the average primary care doctor in the US sees about 25 to 35 patients a day. So that's minutes for you to be able to evaluate a patient and make a diagnosis. Using AI to actually offer our providers clinical decision support, allowing them to have prompts to ask the right questions, order the right examinations to be able to then make a correct diagnosis, to me is really, I think it's phenomenal. I'll just share another statistic with you that 1 in 20 people that visit a primary care doctor will be either misdiagnosed or have a delayed diagnosis. And so from that perspective, if you look at the opportunity for us to let doctors process information in a very different way is, I think, revolutionary. The second area that I feel like AI can make a really big difference in is the way that we engage with patients. Right now, clinical interactions are either done in the doctor's office or in a virtual setting, but it's really limited to that four walls. And everything else that happens outside of that interaction is really the provider is blind to. And so if we start to think about agents as a way to augment the provider's eyes and ears and ability to stay connected to their patients outside of that interaction, that again expands the amount of information that providers have to be able to help patients stay more engaged in their care and actually personalize their care in a much more effective fashion.
I think the single factor that I'm most excited about is probably the speed with which I think AI is going to galvanize innovation and therapeutic drug development in the healthcare space. Prior to health tech companies, I actually worked for 16 years in large pharma corporations, J&J, Genentech, and it always took 10 years or more to bring a drug to market. And right now we have just this excitement of bringing different multimodal data as well as insights and technology into the entire life cycle of treatment development, whether in the lab, in clinical development, setting up clinical trials, recruiting patients who might not know they could benefit from the drug. And I could just see how exciting this could be. For example, my father had Parkinson's. He passed away 3 years ago. It took us a couple years just to diagnose him because he didn't have the tremors, right? So now there's just a lot more information to educate patients. And when he was diagnosed, the therapies for Parkinson's were really limited in terms of, what they could do for him, right? They could not reverse the progression once he was there. So I'm just so excited about the new innovations that can help patients.
So there's clearly a lot to be excited about from the bench to the bedside. And so I want to start to delve into each of the verticals that you're working in a little bit more since we have such a wide range of representation. And Chris, so at Hippocratic AI, you're focused on building AI agents that don't diagnose but do help with care delivery. And so now I believe you have agents doing everything from preoperative care to postoperative instructions. And I have to say, if you would have asked me 2 years ago, and I'm starting to learn that making any predictions is really risky these days, but 2 years ago, I would have said the last place that we would see AI penetrate healthcare is actually at the point of care. And so I would love to hear from you about where you think the greatest innovations are happening with respect to having agents deliver care to patients.
Yeah, it's a great question. So I think generative AI is like the single most innovative thing I've ever seen in my life. I started 20 years ago building EMR, and I built EDC for clinical trials. I've done a lot of classifier AI in terms of doing diagnosis, and we all been through that journey. But the ability for generative AI to actually do things we've never done before is just incredible, because our tendency is just think, what, it's just an agent to replace human. In fact, it's much, much more than that, because agentic AI can do things human could never do, because agent has a superpower. As a start, agent has perfect memory. In fact, we have allowed and asked our agent to memorize every single menu on DoorDash. So if a patient needs a dietary counseling, we can do that. It speaks 14 languages now and counting, so it doesn't require a translator. It has perfect call-to-call memory. I remember every single conversation you ever had. So imagine that in a sort of just a follow-up after discharge, or even in clinical trial setting, we have 10 follow-ups over 5 years. You remember every single conversation. On top of that, it's incredibly empathetic, it's compassionate, and it can do something we call conceptualization. You actually understand things you didn't say. If I can even share a clip with you. If a patient says, "Oh, I'm doing this on Monday, I'm doing this on Tuesday," it's like, "Oh, it sounds like you're really busy." The word busy actually never left the patient's mouth. So I think the reason it's so powerful is that you can have unlimited capability to scale. We're being asked to do a lot of this, what we call disaster response, that only agentic AI could call 1 million people in the next hour if needed. And so being asked to do that both here in US, or in sort of UAE and Saudi Arabia for heat wave disaster response. If there's a heat wave coming, we can call 1 million people just make sure they're okay. The people who need to be transported to a cool area, we can do that. So the potential is limitless in terms of our ability to do things with agentic AI. That's why I think agent will fundamentally change how we deliver care in the future.
So I would love to hear a response from you, Sunita, and Donna too. Do you think that AI will ever fully replace or partially replace physicians and nurses? How about you, Sunita?
Yeah, I mean, I don't see physicians and nurses being replaced fully in the near term. But I definitely feel like we have to start thinking about ways where we can use agents to augment the reach of the care team. And I think that our ability to do that is going to be the only thing that either limits us or unlimits us from unleashing the potential of these types of agents. Right now, I'll give you an example. A lot of preventive screenings all go through the primary care provider. But the majority of folks in certain demographics don't even use a primary care provider. So imagine if we used an agent to stay connected to folks to let them know that they were due for their preventive cancer screening, their preventive vaccinations, et cetera. We'd actually be able to reach people much more aggressively. And so I think we'll have to start thinking more creatively about how we design our care teams to be able to do much more and reach a much broader swath of patients as well. We have a fundamental supply-demand mismatch. You talked about this idea of us being in this in this area where we're always thinking about our limited resources. We are in that situation where we don't have enough providers to serve primary care needs in this country, and so we need to start thinking about ways that we can use this technology to meet that demand.
I think for some specialties, AI has taken up or has greater impact or has played a bigger role. For example, one of my good friends is a neuroradiologist, and so he spends his whole time looking at brain scans. And now what AI is able to do is do that first scan for him, point out a few areas. He still has a role in reviewing patient imaging to identify the tumors, glioblastoma, whatever the issue may be. But AI is able to make his work a lot more efficient. He's able to go through more scans quicker, and I think heighten the accuracy. So it really depends on the specialty that we're talking about.
Yeah, I think that that's certainly true. And if you look at places, right, or especially early on, everyone was thinking about imaging, and we've certainly seen really, really high rates of adoption in radiology and similar specialties. But it's interesting to start to also think about this shift to thinking about primary care and much more if you think about the human sides of those interactions. And one of the pieces that most has surprised me, I would say, about the research is really that with respect to patient engagement, that oftentimes AI is perceived to be more empathetic than physicians, which was shocking to me. But I would love to hear from you, Chris, about the way that these agents have been received in terms of how they're being perceived in terms of providing actual care, and are they perceived as compassionate and empathetic?
Yeah, so we've had, just, I guess, chatbot or this any type of these robotic or machine type of conversation with patients for a long time. It's never gotten this good until recently. I personally was equally surprised, and also what also surprised me after I joined Hippocratic AI, and because I was trying to do this myself previously, how difficult it is to make this happen. There are a lot of nuance to make the conversation seem empathetic, human-like. As a start, we were fortunate we actually received 6 million real patient calls from some of the earlier health institution as an investor. So we actually were able to train empathy by actually having these calls, number one. But secondarily, there were all these little things in terms of just latency. Number one, latency actually matters a ton. Split second makes a huge difference. And then even now, we realize the fact that actually variability matters. If you speak at the same speed and same volume, human don't do that. We speak at variable speed, and we go louder and soft. So, and then the last thing what we're able to do right now is what we call mimicry. We can mimic, not just, number one, the easy thing is language. If you start speaking Spanish, we automatically switch. You start speaking Mandarin, automatically switch. But we can match your education level, match your style of speaking. So there are a lot of these different techniques we're doing now we were never able to do before until generative AI. And so that is why I think for the first time in human history, we're actually able to create agents that truly can speak to human with the level of empathy, the level of persuasion, the level of conceptualization we've never seen before. And that's truly incredible. And I've loved, I wish I could have time to share some audio clip with you. It's just really truly mind-blowing, yeah, for me as well. Yeah.
That is truly incredible. So I'm going to try an experiment. We'll see how this works. But I'm curious to gauge where the audience is at with respect to how comfortable that they feel with AI integration into their own healthcare delivery. So I'm going to give you a scenario, and I'm going to ask you to respond. And I hope you will all respond too, just by raising your hand to which way you would prefer to have this dealt with. And then we can see in general where the room is at on this. All right, so here's the scenario. Imagine this. You've been feeling low or depressed for a while, and you decide to seek help. An AI system trained on millions of patient cases recommends a new antidepressant. It explains the risk and the benefits clearly, and accuracy in similar cases is roughly 70%, which is almost twice as accurate as a human doctor. So these are actual statistics from a study in translational psychiatry, so everyone should be alarmed about the accuracy of antidepressant prescribing. But all right, so you have a recommendation from an AI agent as possible. So here are your three options. So you, the first option, and then I'll go back and you can raise your hand, is you'd feel comfortable starting the medication without first talking to a human doctor. The second is you would want a human clinician to review AI's recommendation. And the third option is you don't want AI involved at all, that you just want a human doctor. Okay? All right. So by a show of hands, how many people would feel comfortable taking AI's recommendation alone? How many people would want a physician in the loop? And how many people would only want their doctor? Me. So I'm going to ask you to respond in a moment. But what's interesting about this is in healthcare, we have primarily defaulted to a human-in-the-loop model. There's all sorts of reasons for this, whether that's regulatory or liability reasons. But in this case, it's been consistently found that having a human in the loop actually leads to worse outcomes. So the physician alone is going to perform the worst. AI is going to perform the best, but AI's performance declines once you actually put that human in the loop. So this is not true for every case. I just want to be clear, but in the case of antidepressant prescribing, it is the case. And if you think about this space in particular, right, and many times we don't need just medication, but we actually need human interaction. And so it's a really interesting case to think about. But I also feel like this starts to bring us to thinking about guardrails, right? Like our default has been human in the loop. As with human oversight, it's going to make things better. But it doesn't seem that that's necessarily always true. And so I would love to think about, ask each of you to think about what is one key issue with AI, with respect to AI in healthcare, and what guardrail do you think is most needed to address that issue? I just threw a lot at you. You want to get?
I can. So the last two companies that I've been working for are what we call big data. I don't know if you guys remember 10 years ago, big data was like the version of AI. So I think in the antidepressive market, there are so many data points. There's such a richness of data that you could feel really confident with a high confidence interval that the recommendations are accurate. But in some cases, some disease states, such as rare diseases, there are not a lot of data points, right? So the AI is only as good as the data that you input into it. And I think a factor that is exciting is getting all the data points together. I think a challenge is that healthcare is such a siloed industry, and with regulations as well as patient privacy concerns, that there aren't enough information made available universally to AI models. There are companies working with large pharma, with life sciences companies that work within those institutions to bring those data sets together, but they're not often publicly available.
Yeah. I would agree with what you were saying in terms of I would have to, as somebody whose license is on the line for prescribing, I would want to make sure that the information that the model has has all of the components that would be there to make sure that I'm not causing any harm. I think that's the biggest challenge is right now, the liability right now still lies with the clinicians, and so they need to feel like the model has asked all the right questions and understand where they, what data they're using, be able to reference that data so that if they want to double check or follow up, they have the ability to do so. And so I raised my hand that I want a human in the loop for those caveats, that I'd have to have trust that the model has all the right components.
It's an interesting challenge, though, as you started to lay this out, like thinking like, oh, as a clinician, I would want to check the recommendation, and you want some explainability.
Yeah.
But if you think about, right, like when you are working at delivering care, there's so much going on. You're under so much stress, and even getting a medical education is already so complicated. But then, if the physician's going to be doing the oversight, that means that they actually have to understand to some degree how AI works.
That's right.
And so, do you think that that's realistic, or from an educational standpoint, how should we be thinking about training physicians in order to deliver care in this new era?
Yeah, I mean, when you were going to ask me later on what I think the biggest challenges are, I think that training and trust are probably the two biggest challenges. Medical school education has been fairly stagnant for many years. I know we've talked earlier about our business school education. I think medical school education really has to evolve to start to understand these tools better and make sure that people that are graduating from medical school have these as part of their repertoire. In the same way that they use MRIs and CT scanners to make diagnoses, they need to have fluency in these tools.
I like that, training and trust.
Yes.
How do you think about safety and guardrails?
I think this is a critically important question. We spend a lot of time thinking about it. First, I think we need to clarify what do you mean by human in the loop. There are at least two different kinds of human in the loop. There's one kind where humans always in the loop, meaning that after I talk to an agent for maybe 20, 25 minutes, that always gets routed to a human clinician. Or one in which what we're doing now, we've built a very sophisticated escalation engine, which means that only in certain instances it gets escalated to a human. And in fact, the majority of time, it doesn't need to. And this is critically important because it comes down to whether or not it's a co-pilot or autopilot. And I think the issue with the co-pilot is the fact that it sounds great, but the issue is that you can never scale. And you get maybe 10 or 20%. Your ability to scale always dependent on the fact that you have a co-pilot there. So it's great, but you can't scale. You could never get to a level where we will truly have abundance. That is why we, really focus on what we call it's a escalation engine that is technically human in the loop as needed. And the hard part is how do you build a escalation engine that's so good, and that will be able to do that. And we've spent a lot of money. I won't tell you how much, building an escalation engine. And we all know there used to be a company called Babylon that tried to do that, and it didn't work because what's the problem? They were escalating 50% of the calls. Well, guess what? It didn't really help if you're escalating 50% calls. So we believe that we need to get to a place where it's human in the loop, where that, and we track our error rate. We actually then review it and we put it like red, yellow, green. It's surprising that, number one, it's not going to be perfect too, because this is one is perception that was AI is going to be perfect. It doesn't need to be perfect, it just needs to be better than human. And that's how we track, our error rate. So is that better than human? And we're continuously improving on that. That's number one. And I think what's equally as important is the fact that by doing that, the human in the loop, the job of human fundamentally changed now, because what happens, your capacity just increased by 10x. So instead of you making, say, 10, 20 calls to 20 patients a day, well, guess what? AI is making 200 calls. And your job is that you come in, you review the transcript of whatever, the output of those 200 calls and decide the fact, well, there are 5 calls you need to call back, and the answer 195 is fine. So your job actually fundamentally changed as a clinician. Yeah, you become the supervisor of the AI. And you're still making some calls, a human in the loop, but it's a human in the loop, not in the traditional senses that, every call after a call gets transferred to a human. That's not, I think, the biggest opportunity for agentic AI. The agentic AI is really that our ability to perform latter, to build an amazing escalation engine where we can truly have abundance. We can truly have 10x or 100x of our current capacity. I think that's where we're going in the future.
Thank you for that. I love that vision and inspiration. And even though that we're talking about AI and we were talking about biotech this morning, I have somehow broken the iPad and can't get the audience questions. So I am hoping someone can come and help me. And in the meantime, we've been thinking a lot about patient-facing care. But I also want to circle back and think about the ways in which AI can be impacting other aspects of healthcare. And so we've thought a little bit about drug development. And Donna, I was hoping that you could say more about where we may be able to utilize AI in sort of expediting clinical trials, which is a really big problem as we discussed this morning.
Yeah, I think Sunita, for example, alluded to misdiagnosis or underdiagnosis in the healthcare space. One of the ways in which AI can help accelerate innovation is through education of physicians as well as patients. So for example, at Komodo, I worked with a client, which is a mid-size biopharma company with a drug that they developed for a rare disease. Only about a few hundred to 1,000 patients have been diagnosed with HoFH, homozygous familial hypercholesterolemia, and they wanted to find more of those patients because those patients are not even aware that they have HoFH. And many physicians are not actively thinking about it. So what we did was we built a model identifying patients who had been diagnosed and tracked the model based on the historical lab results, tests, hospital encounters, outpatient clinic encounters, and built a prediction around, what is the likelihood of a patient having HoFH. And we were able to deliver thousands of patients to the client. I'm not saying they were all accurate. There were, varying levels of confidence intervals. But I am happy to say that, we were able to identify a handful of patients for education. Of course, this is de-identified, targeting the HCPs or the physicians that are seeing those patients. So really identifying the patient population is really important. And then once you have a drug that is in the clinical trial setting, I talked about multimodal data. Now it's, even in the lab, you're able to bring together imaging, EMRs, lab results, genomics, to really inform whether you think an asset is going to have a response. And then secondarily, after the lab, I think in clinical operations and clinical development, using AI and data, we're able to quantify the impact of the drug, and we're also able to help clients with really shaping the trial design. How many patients would they like to recruit? What are the inclusion-exclusion criteria? Those are really critical because if you have too many inclusion-exclusion criteria, you could get to such a small population that you never get that trial recruited and you never get the trial done, right? So getting the operable and optimal sample size with the right inclusion-exclusion criteria, and after that, we're able to use AI as well as real data to identify where those patients are, understand which sites are seeing them, and then actively work with those sites to recruit those patients. And hopefully this 10-year-long decade exploration of getting a drug to market will shorten, and we can bring things out in greater speed going forward.
I certainly hope so. I feel like that there's a place of immense promise. So we've spent a lot of time thinking about care delivery, which is often where, and patient experience, which is oftentimes what I'm thinking about. We have a classic Wharton question that I would like to put out to all of you, which is, what specific clinical or operational use cases are showing the most tangible ROI in healthcare? My guess would be clinical trials is one area that you're seeing a pretty significant return on investment. Are there other areas that come to mind quickly?
From whose perspective?
I think that that's a really good question. My guess is the question is from the business side of things. So we could think about, certainly I know in insurance companies using AI to process file claims, and claims is a huge area where there's a significant return on investment. But Chris, given the labor shortages in healthcare in particular, and that we know that labor occupies the majority of spending within healthcare, have you been able, or can you talk about the potential return on investment for starting to use agents to arguably replace some of those labor costs?
Every one of our clients asks us that question about ROI on our agent. The reality of it, to be perfectly frank, we're a little too early to really give you true, robust, Wharton-like number. But we've seen some early signs on special use cases are fairly obvious. We actually have a large number of use cases now, 400 plus, and we're putting them in a pyramid, anywhere from low complexity to high complexity, but sort of low volume. And the places where it's very obvious, for example, using our agent for perioperative care. And the idea is very simple. Our agent can call, for example, a pre-op colonoscopy. Right now, you have both, some of you probably have experienced that. One call. But the reality is, if you have unlimited resources, you can make 5 or 10 calls. You call them 7 days before telling them what meds to stop, 3 days before they tell them to, at the time of, when your actions happen to stop your blood thinner, 24 hours before teaching them how to do their, go lively, and then 24 hours before telling them to NPO, and then, if they need to reschedule and things like that. The whole idea of it, we actually decrease the no-show rate, or the chance of they didn't do something correctly, they showed up and the case needed to be canceled. And the cost of that for the hospital is huge, right? They come in, you will earn like, I don't know, $1,000, $2,000, $3,000, all of a sudden, boom, zero, gone. So our ability to prevent that from happening, just all we need is a few cases and the ROI is simple. And so we're being able to demonstrate what we call perioperative call, and very quickly being able to show ROI on that specific use cases. There's only one problem. The problem is we contract on a system level, and there are like a lot of different use cases. Well, the volume of that is small. So even though on individual cases you look like, well, it's huge, but then, well, how many colonoscopy do you do a day? Versus the fact that there's some very large volume type of things we can do, like calling everyone during flu season to tell them to come in to get a flu shot. So on individual level, you probably don't get very high ROI, but like on a population level, we could probably get very high ROI, but we have not been able to truly measure that. It takes much longer time. But I do fundamentally believe in the future we'll truly get to value care. That's why at least 3 out of the top 5 insurance companies are in serious engagement with us about doing things on like millions and millions of people, and to be able to demonstrate that.
And I love as you talk about thinking about this from a systems perspective. There was another great question around issues around like how do you actually get over the resistance to implementing AI in healthcare systems? And I always say, right, that this is actually, I mean, obviously safety and efficacy and explainability are huge, but I would say in healthcare actually implementation and system integration are the biggest challenge. And so I would love to hear from you, perhaps Sunita, how do you think about overcoming some of these challenges around just the natural resistance healthcare systems in particular have to implementation and integration?
Yeah, I mean, I would say what I've seen so far in health systems around the country are the 2 most common places where we're using AI are in ambient scribing, and then the other one is in automating responses to messages. Those are 2 huge pain points for providers, a cause of lots of tasks in their inbox that they end up doing late at night. And even though providers who use it are able to say that, hey, this has made my day much easier, I go home with 0 tasks in my inbox, for many it's still very difficult to implement because it takes training and like reworking your, I call it the choreography of your doctor's visit with your patient so that you are comfortable instead of being hidden behind a computer to actually look your patient in the eye. For many years, docs haven't done that. And so it will take a little more training for folks to feel comfortable with that. But I think the more provocative question is a lot of folks are asking, well, if you're asking me to do this, take away all my inbox tasks, does this mean you want me to see more patients? And so I think there's a little trust on that end that needs to be addressed as well.
And what do you think the answer to that question is?
Yes.
Always yes.
Yes, the answer is always yes.
So it's just a reallocation of labor, perhaps a better usage. So with our last few minutes, I would love for each of you to say if you had one way of making AI better for healthcare, whatever better means, what do you think the most important thing that we can be doing right now is? Donna?
Well, I think I alluded to it a little earlier, which is that because of regulatory concerns and privacy concerns, there is really a limited amount of data available for technology companies and AI platforms to leverage all the necessary insights to make the informed recommendations and decisions. So we saw a little bit of collaboration during the COVID era when companies came together, shared information, shared insights, and really developed quickly vaccines and treatments, right, in record speed. That's the only time I've seen things come out in less than 10 years. So to the extent that we can make more resources and insights available for these models, I think that will make a lot of the recommendations and the education that comes through more accurate.
So more collaboration?
More collaboration, for sure.
Excellent. How about you, Sunita?
I think it is collaboration. I think that the ability to pull together the right data or enough data to make the AI, the large language models, trustworthy from a clinical perspective is going to be really important. I think the second one is less about the AI and more about the industry, and really thinking about how to use the AI to innovate on how care is delivered rather than tweaking the existing model, and really thinking about how do we blow it up and start over, because I think as we try to retrofit it to our existing model, we're going to be our biggest barrier.
Yeah, I feel like that's always been one of my biggest concerns is I don't want to, and I was trying to on a positive note, but right, if you argue, and I think there's an argument to be made that actually in many ways healthcare is a fundamentally broken system, and we're asking AI to solve that problem, is actually not going to work. It's just layering AI over an already broken system. And so I love this perspective that if we want to use AI well, maybe the way to be using it is to redesign the system. And that's incredibly powerful. Thank you. Chris?
I'm going to give you a little different answer. It sounds like a technical question, but actually my answer is a non-technical answer. It's more like a political answer. I think the technology will be amazing. You would do anything you wanted to do. Our biggest challenge is actually the decision makers. This goes from anywhere from the institutional level all the way up to political level, including EU, such as EU AI Act, which fundamentally actually right now block us from entering any of the EU countries because it's just not operational for us, that we're not able to really do things that we would like to do. And so I think the biggest thing we could do to make AI better is to educate all the decision makers at every single level so they truly understand not just the power of AI, but how it fundamentally will really change how we deliver care and have them embrace it. Of course, there are risks, there are challenges, but so is everything else. And so really understand what it is. And I think a lot of them are overreacting due to ignorance. And I would encourage all of us to educate all the decision makers to make sure that they embrace AI in the future for healthcare.
Well, thank you all for coming together to collaborate and educate, which has hopefully helped us all build trust and training to make AI better for healthcare. So thank you so much for being a wonderful audience and joining us for the discussion today.